Good evening. I'm Wade Hemsworth from McMaster University's Office of Communications, Marketing, and Public Affairs. I'm pleased to welcome everyone to our expert panel discussion on COVID-19 and vaccine reluctance. This event is the result of a joint effort by McMaster and the Conversation Canada, a nonprofit academic journalistic collaboration of which McMaster is proud to be a founding member. Tonight's panel is part of an occasional series of COVID-related panels by the Conversation. We're pleased to welcome a group of experts representing some of the deep and broad COVID expertise we have at the university, which all comes under the umbrella of McMaster-based Global Nexus for Pandemics and Biological Threats. Our moderator tonight is Scott White, Editor-in-Chief of the Conversation Canada, which launched in 2017 and is part of a global network of partner organizations in other countries, including Australia, the UK, the US, and others, all working to publish explanatory and analytical pieces by academic authors on topics of public interest. Under Scott's leadership, it has become a vital national platform for informed contextual discussion. Scott is a highly respected Canadian journalist who previously served as editor-in-chief of the Canadian Press and as VP responsible for content strategy and business development at Post Media. He is a friendly guide to our McMaster team, including our academic authors. The Conversation's talented and experienced stable of editors assess proposals and help authors tell their stories in the most accessible, impactful ways possible. Tonight's event, A Literal Conversation, is a logical extension of their work, particularly during this prolonged COVID crisis. Let me introduce our panelists. Zain Chagla is a medical doctor, educator, and researcher whose specialties include infectious diseases. He is familiar to many as a reassuring presence who explains and interprets the complexities and the changing picture of the ongoing pandemic through the media. Zain is an associate professor in McMaster's Michael G. DeGroote School of Medicine, a researcher heavily engaged in understanding aspects of the pandemic, and a clinician with St. Joseph's Healthcare in Hamilton. Don Bowdish is a celebrated immunologist, a professor of medicine in the DeGroote School of Medicine, and holds the Canada Research Chair in Aging and Immunity. She is frequently called upon to comment on and explain pandemic-related issues to the public. We know her as a strong and conscientious advocate for public education about the pandemic, a role that includes both writing for and encouraging others to write for the Conversation Canada. Manali Mukherjee is an assistant professor in the Division of Respiratory in the DeGroote School of Medicine. Her research includes intense work on developing aspects of the pandemic, including long COVID, an outcome of acute COVID infection that features lingering symptoms that can sometimes be severe. As a long COVID patient herself, she knows this issue from both sides. Clifton van der Linden, an assistant professor in McMaster's Department of Political Science and director of the university's Digital Society Lab, specializes in the implications of technology for the practice and study of politics. He is the founder of Vox Pop Labs, a social enterprise known best for producing the Vote Compass. Vox Pop Labs has been taking the temperature of public opinion regarding COVID throughout the pandemic. There is much to discuss tonight, so let's get to it. Scott?
Thanks very much, Wade. It's a pleasure to be here. I'm speaking to you from downtown Toronto with all of these fantastic experts from McMaster. Wade's explained what the Conversation is. You can always find us at theconversation.com. This is a night where we're here to answer questions from the public, and I'm the liaison between the questions coming into these experts. So I'm going to start right off with some questions. And one of the questions I have, because this is about vaccine hesitancy and vaccine confidence, and I want to ask all of you, how many of you have a vaccine hesitant person in your inner circle? I know I do. I have someone in my family. And so tell us about if you do and what you have tried to say to them to persuade them that vaccines are safe. And who wants to go first?
I'll go first because I think it's important to learn from failure. And all the good practices that I use with strangers, I have a hard time implementing with my own family. And so I think with all things in life, one should always listen more than one talks. I think one of the important parts about vaccine hesitancy is it's not my facts versus your facts, and I have all the right facts and you have all the wrong facts. Because that's people who are vaccine hesitant have lots of information, and there's no metric to say that makes them feel that my information is better than theirs. So I feel like listening to people's concerns and being really specific and not making judgment calls about what their concerns might be, because to be honest, the vaccine hesitancy spectrum is huge, as we'll hear, I'm sure, a little bit more about, and people have different challenges. So where I have gone wrong with my own family is doing all the things that you shouldn't do. I talked more than I listened. I threw scientific facts as opposed to listening to people's stories and concerns. And I appealed to the authority. I've got a PhD. I've been working on this for 20 plus years, and that was a mistake. And so those are the things I would caution people against. And when you have your own conversations with your vaccine hesitant family members or friends.
Zane, what about you?
Yeah, no, I think again, Dawn put together some really good examples there, and I agree. It is a huge spectrum, right? There are people that are very, the kind of characteristic anti-vax out there, but there are people that have legitimate concerns, and it is individualized in that sense, right? So number one, you are an incredibly powerful person, being a person of trust in that person's lives. Often as a clinician, I can't even get to that point to people because, they obviously know I have an agenda to begin with when I start talking to them. And certainly the people close to me that we've had to have long conversations about, it became, not about the scientific facts, but just kind of saying, where personally did this come from? What things scare you about this? What do you think the worst case scenario is here? And really just getting to that individual and understanding them, being compassionate, and using yourself as an individual as the sounding board for that, right? You may not get to the answer you want, but at least you build that trust. And I mean, we know from things like smoking cessation, where the more times that conversation happens in a non-judgmental and non-confrontational manner, it often ends up with the right outcome at the end of the day. So again, it's not a conversation to win to the other side and get someone to the pharmacy that afternoon. It's a conversation to start another conversation and start another conversation and keep going along those lines.
Manali, we want to ask you about long COVID in a moment, but in terms of, do you have someone in your inner circle or your family where this is an issue?
I think we all have that one or two person in our own family, in our own extended family and friend circle. So yes, and I completely echo Dawn and Zane out here. And I've seen how my tone and what words I use in explaining this has changed over time, because soon I realized that just holding a banner saying, hey, I'm an immunologist is not helping, because being an age of information and misinformation has been at the fingertips, and everybody has become an expert. So I learned it the hard way and started to listen more. But what I usually have been trying to say, and it seems to resonate a little bit, is that there is enough data that if you get vaccinated, the number of cases can go down. You cannot question that. It's statistics there. You may end up having a mild disease, but somebody else may catch it from you who may be pretty severe and have much more long-term effects. So think about it as a society and ask your own conscience. And still then, not really. So I try give out what I can and then accept what people will actually take it as their opinion. Simple.
Cliff, we're gonna dive into in a moment about issues of trust, but you've done a lot of work on taking the public pulse on this. But in your personal life, what have you learned on trying to convince someone?
My experiences are similar to the other panelists, except for the fact that I am not a specialist in the way that they are, so I don't have the same appeal to authority. But I'm glad that you brought up trust, and trust has and I think trust is the common theme that you've been hearing from everyone here already. And certainly, no matter how we model the public opinion data coming in on attitudes towards COVID-19, when it comes to vaccine hesitancy, trust is really the major factor. And I think we're in an era where there's a real sense of anti-intellectualism that's being cultivated in certain I will say corners of the internet, because I do think that the social media discourse has a huge role to play in the way that trust has eroded as a society. But there are factors in the way that government has conducted itself. There are factors in the bad faith in which certain public actors have conducted themselves. And so there are lots of reasons for mistrust at an institutional level, I would say. So I do think that trying to ground conversations with people we love in that framework of trust, knowing that we are concerned about them, that we're approaching them not because we want to be right, but because the consequences of them being wrong are so dire for themselves and for our families and loved ones. I've had limited but some success in trying to approach this more from the heart than the head.
I think that's a really interesting part, the heart versus the head. One thing that's always puzzled me is that there seems to be this really rabid reaction against vaccines, but maybe not other medical conditions like surgery, which is far more invasive, medicine, taking pills. Why is that? What is it about vaccines that really seems to cause this hesitancy or resistance in some cases? Who wants to jump in on that?
I have a theory that is partially to do with it being a needle. And I think my colleagues at McMaster are working on vaccines that can be inhaled. And I'm amazed at how people perceive that as being less of a medical intervention, because we breathe every day, but we don't get needles. So I think there's part of that. And I think also, the tremendous power of the immune, now maybe I'm biased as an immunologist, but the tremendous power of the immune system, the active ingredient in our current vaccines is like 10 micrograms. So if you go and look in your medicine cabinet, your Tylenol, your Advil or whatever, you'll see that we work in milligrams, but 10 micrograms, 1,000 times less, has this incredible, powerful effect to be able to create a whole immune response. The amount of stuff that's in the vaccine is negligible. It's nothing. It's really, but this incredibly powerful immune event, I think, is a little bit humbling in some ways. And so my belief is that it's partly because it's a needle and partly because there's this big mystery about how the immune system works and how it could be so powerful.
And what about the role of the internet, spawning this resistance? Cliff, I mean, you're kind of dealing with that on a regular basis, I guess.
I think that we've especially in the last 5 or 6 years, we have been flooded with discussions of fake news, misinformation, disinformation. I mean, we're told not to trust what we hear from government, depending on who's running government, and the idea that you can trust one day and then not trust the next when there's a change of actor or a change of party. It leaves people in this state of constant cynicism about the good faith of, I think, of particularly of elected officials, but also of government institutions in general. I think there's a difference in Canada compared to countries like the US, where in Canada, we do see that the public tends not to trust elected officials, but we still do have a lot of trust in our public health institutions in Canada. And I think that might be why you do see a significant difference in both perceptions of the safety and efficacy of vaccines in Canada and their uptake versus the United States. So I think that fundamental trust among the Canadian public and in our public health institutions is vital to ensuring that people have enough confidence in the safety of vaccines to take them.
So one of the reasons, so at the conversation, we've been running a series of articles about vaccine confidence and vaccine hesitancy, and been inviting questions from the public for several weeks. And sort of one of the recurring questions that we get is that people seem to have trouble wrapping their head around the fact that the vaccines that have been developed so quickly, the vaccines for COVID. So, and there are concerns that scientists don't know about the long-term effects. So how would you address concerns about potential long-term effects? And in particular, we get questions about what does this mean for kids as children are now being vaccinated? And what does it mean? We get a lot of questions about potential harms of fertility or people who are going to be pregnant, plan to get pregnant soon. So can I ask all of you to weigh in on that, about this whole idea that, wow, this happened so quickly, how can you trust it?
I think Dawn can talk about drug development better than anyone here.
Truth, it's been several decades in the making. So the apparent speed was based on decades of fundamental research, and I love this as a story because oftentimes as a university academic, the general public thinks we waste time working on things that are going to be, that are fundamentally unimportant. They want to hear about our studies of fruit flies and mice and things like that. But the idea that you could use messenger RNA as an example to encode a little bit of protein that the immune system could see was sort of an academic bit of fluff, and then the idea that we had to find a way to keep it stable so we could hide it in a lipid coat and administer it. Those took decades. And in fact, we did have mRNA-based vaccines in the pipeline for many different infections. And one of the beauties of the mRNA technology is that it's fairly easy to alter. So in fact, I think it's about 3 decades. And to be honest, many of the features of vaccination, the dosing intervals, the amount of doses, how we develop things for kids and for adults and older people are all based on decades and decades of experience. The safety issue is one that I think we really need to, again, I am humbled and awed by the immune system every single day of my working life. And the fact of the matter is what we do with the vaccine is it's ephemeral. The parts of it are degraded and broken down so quickly, but the immune response is exquisitely specific. It takes 6 to 8 weeks to make a fully formed, mature immune response. And so the side effects you see with vaccination are almost always within that 8-week period. We don't have a single example of a vaccine leading to long-term fertility issues or leading to, I don't even know what people are envisioning with the context of fertility, but the immune system attacking your ovaries or whatever. And in fact, all those mythologies, I think, were incredibly clever by the anti-vax crew, because if you're a parent, what more do you want than grandchildren? And so, what is going to trigger your emotional response and your desire to wait and to see more than that threat? I still remember taking my baby daughter for her first set of vaccines. When she was 3 months old, she had those beautiful chubby thighs that they put the vaccine in. And despite my decades of learning, having this second of, because it seemed like such a powerful tool. So I'm sympathetic, but believe me, with 1 billion doses and everyone being either 6 to 8 weeks back, there are no more surprises left. We know what's going to happen, and there's never been a case where we see decades later challenges associated with a vaccine.
Zane, from a medical perspective, the dangers of not being vaccinated if you are pregnant, or the potential harm to children.
Yeah, absolutely. Look, no one is going to deny that, people get through, most people do get through their infections and don't die. I think we know this very well. But it doesn't say that everyone is safe. We do know that, elderly people are much more risk of complications. We know that people with comorbidities are much more risk of complications. And we have seen young people who, despite looking great on paper, are sitting in their ICUs ventilated because, again, once this virus gets out of control, once the immune system gets super jacked up, it really can cause chaos. And we sometimes don't know who is that person that it's going to be chaotic in and not. pregnant women, I think we're recognizing much more are in that risk group now. And we have seen some fairly sick pregnant women. They're physiologically unwell. They're obviously carrying a baby, and that, the concerns of having severe COVID, not only in the mother, but in the baby, are also a major issue. And unfortunately, we've had to deliver babies prematurely for the fact that it would spare the mother their lives more and make their mother's oxygenation better. So, again, there are lots of complications here, and we'll discuss long COVID in a moment, but recognizing that it is a bit of Russian roulette. Not to say that we're not destined to get COVID at some point or be exposed in our lifetime. This virus keeps evolving and it keeps changing, and burdens get higher. But going into COVID with an immune system, as Don has talked about, as powerful as our immune system is, giving it a head start to deal with this infection early is going to be what saves us more than anything else. And we've seen this with other pandemics. We've seen this with other vaccines. We deal with breakthrough cases, with vaccines all the time, but we know there is a physiologic difference in terms of that person's complications from being immunologically naive or not having any immune system or trying to scramble for their immune systems to deal with the virus, versus people that have a head start. Even if they do have a breakthrough, their body knows what to do with it, and it just kind of keeps it under control and leaves those complications down. So, again, there, as much as we would say everyone's going to be fine, we don't know who's not going to be fine. And it surprised me every moment of this pandemic, the people I see, some of them I would, are healthier than I am, and I'm not that healthy, but much healthier than I am in that sense. But again, it's, we know profiles that are higher risk, but we don't know everyone's trajectory, and knowing that this is probably the most powerful intervention to change people's trajectory, it really does need to be put out there. And again, our pregnancy discussions have really focused around this. We have good data in pregnancy. We have good registry data from the beginnings to ends of pregnancy, showing no difference in fetal outcomes. And again, we know now that critical care stays amongst pregnant women are higher than they've ever been, and recognizing that is a risk factor for bad outcomes with COVID-19.
Manali, you've not only researched long COVID, but you're dealing with it personally. I'm not sure that people fully understand the term and the impact that it can have on your life. So can you tell us about that, and then also speak about the best way to avoid it?
Right. So a considerable proportion of people who have been infected with COVID-19, irrespective of how severe they were, whether they were in the hospital or whether they recovered at home, they continue to have symptoms or actually develop new symptoms long after they have so-called been termed as recovered. So the public health gives you that call and tells you, you have recovered, you can, if you're feeling fine, go back to work or whatever. But there are a number of people who still feel sick, who have lingering symptoms. These symptoms can range from anywhere from chronic fatigue, sense of smell not being there, completely being distorted, having diffused pain, and of course that leading to all this anxiety, palpitations, and cognitive impairment. So it's a constellation of symptoms that's kind of lingering. And none of these symptoms can be attributed to a clinical diagnosis that they either had before getting COVID, or the fact they can now say that, oh, I have this diagnosis. So it's something completely quite a mystery, but they have these symptoms. So initially, when this was coming across about 12 to 15 months back, around then, UK started first coming up with a definition of long COVID and said, these are symptoms that are there 12 weeks post-recovery or other. But now we call them long COVID, and we're trying to look at what might be the reason behind it. I have reasons to believe that it's deep-seated again within the immune system. I think that after having COVID, the immune system is still so hyper, and it still thinks that the virus is possibly hiding somewhere, or there is something still going on, and the symptoms are a clinical manifestation of that misunderstanding that the immune system has. So that's what we are trying to right now unravel and understand. So
who's more susceptible to this? Is it younger people, older people?
That's exactly what Zane said, just the way we didn't know what's going to affect during the acute phase of the infection. Like, he has been surprised by younger people ending up on a ventilator. Same here. In my study, I'm seeing people from all age groups, all ethnicities coming in, even asymptomatic people, like people who had the infection, PCR positive test was asymptomatic. Now they're having symptoms. So really, we don't know who's going to get affected, why they'll be affected. And worse, we just don't know when this will stop or whether it will.
So one of the things that it's fascinating over the last 2 years, all these terms have entered our vocabulary, social distancing and things like this. And one of them is herd immunity. I had no idea of this term until it started to come out. And so there's been a lot of discussion about herd immunity and social media every single day, instant experts, who this debate that natural immunity is better than being vaccinated. The other thing is that, and again, I deal with this on again, somebody in my inner circle who says, hey, you know, I don't get sick much, so I'm going to be okay. Dawn, tell us about herd immunity, natural immunity versus vaccinated. What should people really be focusing on when it comes to these terms?
Well, I mean, Manelli just gave you an example of natural immunity, right? So long COVID is a natural immune response in some people. And I remember when Manelli and I were working on our first study on long COVID, I remember my postdoc who was doing the immune work, we were looking at the blood together and she said, I'm not afraid of getting COVID, I'm afraid of long COVID. So that's a great example of natural immunity. Natural immunity is also what Zane's told us about with some of his patients being on various aspects. So I also don't think there's anything unnatural about a vaccine response. It's giving your immune system the opportunity to work without distraction. Right? So when you get infected with a virus, the virus doesn't just say, oh, woe is me, the immune system's coming to get me. It's destroying tissues. The immune system in many cases is misdirecting and attacking those tissues. So some of the tissue damage we see is mediated by natural immunity because it gets confused when there's tissue damage in the context of infection. So natural immunity works sometimes, but vaccine immunity is natural immunity. It's immunity working without distraction, letting the immune system do its thing without having this virus that's fighting back and trying to thwart it. If I ever hear the word herd immunity again, I'm going to have to smack somebody. And Scott, I'm looking at you. You know, the thing about herd immunity is, let's go back to a time before we had vaccines, antibiotics, and doctors like saying, 1 in 3 to 1 in 5 children died. There were more miscarriages, spontaneous abortions, and babies born with severe complications because having an infection during pregnancy is problematic. Sure, if you were one of the lucky ones to have survived your 5th birthday, you might have some level of protection until you got older or until you had some immune compromising event or other illness. So a herd immune system gives a small percentage of the population a little bit of time to be protected from that. But as soon as a new baby's born, a new pregnancy started, that susceptibility happens all over again. So the idea that we would just let a new virus run rampant in a population and take those risks to the young, the old, the random healthy adults is just cruel from my perspective, really cruel. The best way for us to reach herd immunity is to get us all vaccinated. It looks like we're all going to get Omicron at some point in our lives, right? So you've got 2 choices. You let your immune system work without distraction in the context of a vaccine. When Omicron and it comes to you, you have a good chance of having asymptomatic to mild infections that you can handle at home. Or you gamble and you ask yourself, do you want the natural immune response that might end up with long COVID or other long-term complications, or might put you in the hospital? Now, fortunately, we've got doctors with new therapeutics like Zane to help you through that, but that's not a gamble I'd be willing to take, and I hope it's not a gamble anyone I care about would ever take.
So you touched on one of the big words from tonight. Again, I knew nothing about the Greek alphabet except I think from watching Animal House, the movie. So now we have Omicron. Am I even pronouncing it right? Is it Omicron? Omicron? I guess it doesn't matter. We know what it is.
Call it the big O.
The big O. Yeah. Zane, tell us what you're seeing so far, but more importantly, what you're worried about, and talk to us about how effective current vaccines are, including the issue of getting the booster.
Yeah, I mean, this is different, right? This is so, I don't want to say this is March of 2020 as there is, because people have gotten vaccinated, and unfortunately because people have gotten COVID, there is a lot of immunity in the population, which is a good thing. But what we're seeing in South Africa is something that we've never seen before. When Alpha and Beta and Delta emerged in the world, they were fitter, they transmitted more, they were more severe. Delta had a little bit more immune escape, Beta had a bit more immune escape. They were a little bit, but it took weeks and weeks and weeks for them to kind of replace. And again, amongst populations where we were public health measures, we saw Delta emerge in Canada, which in Ontario hadn't actually been that bad because we actually had a lot of vaccine-derived immunity, and it really did protect much of the population. But South Africa is seeing Omicron at another level. And, they have seen within 2 weeks of raising the alarm here that essentially everything is Omicron. And what the world is seeing is the exact same thing. We heard about our first Omicron case in Ontario, I believe at the end of November. Tonight, I think it's about 30% of the isolates we're getting in the lab are Omicron. That's unheard of. The strain has completely replaced, the variant has replaced prior variants within the matter of 2 weeks. And the growth potential, I think, here is the biggest thing that we're worried about more than anything else. And so in South Africa, just going conservatively, adding 10 times as many cases that are being diagnosed, given that it's a mixed private public healthcare system and access to testing may not be as appropriate. A lot of people are doing rapid antigen tests at home. Being conservative, about 3 to 4% of the population now has Omicron at this moment or is an active case. Being not conservative and talking to some folks on the ground, as they're testing people coming in for, pregnant women coming in for deliveries in Tishmani, which is the area that's kind of the epicenter, seeing 30% of people test positive coming in. 30%. That's a sample of the population that is just remarkable, right? For a variant that didn't exist, for a population that had a lot of unfortunate natural immunity because of our vaccine equity issues, where suggestions of 80% of the population had likely been infected in the first 3 waves, we're still seeing, 30% of the population in some regions being infected. And so certainly there's a concern as it gets to our soil. We'll see a lot of cases here and a lot more cases than we've ever seen before. There are elements of immune escape here that are different than any other variant in the past. And we are getting data now out of neutralization studies, so lab studies looking at vaccines, suggesting that antibody levels, even after 2 doses, may not be as effective for preventing it, not necessarily for preventing severe disease. And now clinical data from England that really suggested that, with AstraZeneca, very little prevention from getting infected. With Pfizer, about 30 to 40%. The good news is we're also seeing booster data suggesting that, we're seeing almost a restoration of immunity, kind of back to the 70, 80% ballpark with getting a booster shot, no matter what your primary series was. We're seeing in South Africa, even their data suggesting the same thing in a private healthcare network today that released their data similar, but 30% efficacy of Pfizer 2 doses, 70% efficacy against hospitalization. So it's still a good reason to even have 2 doses in your system than 0 doses. But again, the fact that this could transmit both in vaccinated and unvaccinated populations makes a big difference right now, is Delta largely kept to unvaccinated populations. The fact that, this concept of herd immunity, where people, if they're highly vaccinated or highly immune, they're going to protect people that are unvaccinated, essentially breaks down now. And so there is no protection from any member of society from another member of society. And as more people get infected in both sides of vaccinated, unvaccinated, there's going to be more unvaccinated people that are exposed to this virus for the first time. And I think, being someone who works in a hospital, all of us are, even if it is a small impact and we're not sure about the severity piece, even if it's the original Wuhan coronavirus, the one that was described before, that just rips through the population with this high a number, and the severity is largely modulated by vaccines, but is many more cases than we've dealt with before. A small percentage of those cases will still need hospitalization. And right now, our healthcare system is burnt to a crisp. We can't deal with our current caseload because we have complex patients coming in every day. We have ICU beds that are still allotted for COVID patients, and we have healthcare workers that are burnt out and have left the profession and are not coming back. So there is a lot of worry in the coming weeks and months as this circulates. We're going to see health systems overload. We're going to see a lot of people test positive regardless of the vaccine status. And we're going to see a lot of isolation and complications from that. The good news out of all of this, though, is boosters do seem to really change the dynamic of vaccines and offer higher level protection. We're getting better data by the day that really is suggesting this. And so, I think there is work being done right now across the country, and particularly Ontario, to make sure people do have access to a booster shot when their time comes.
Manali, what are your thoughts on this?
What worries me right now is we don't know much right now about the long COVID cases that we have, as in from the original virus, the Wuhan virus, to the alpha, beta, delta strains, how long COVID symptoms vary. And now the Omicron has come in, where we don't know how it's really going to be affecting our immune system, given that it seems to have a higher transmissibility. And despite having been said, despite having a milder load, we don't know how it's going to really affect those with a longer COVID kind of situation. Will it affect more people with lingering, longer, persisting symptoms than actually having a more severe acute infection phase? We don't know. So I think if you are getting vaccinated, if you are vaccinated, there is data out there that it kind of reduces your long COVID symptoms. So if you are vaccinated and then still you get Omicron, the logic tells me that your immune system might be a better streamlined, the way Don said, to handle that infection in a better mode, as to not confuse it and make it more rowdier and lead to those lingering long COVID symptoms. So that is, again, another thing that tells me that vaccination and taking the boosters might actually be in our benefit as a society and community, going towards natural immunity or herd immunity.
I do want to mention quickly that Dawn has co-authored a great article that we have on our homepage today at theconversation.com about how vaccine inequity has actually allowed Omicron to emerge. But I want to turn to Cliff for a moment, because one of the things as a journalist that I find so fascinating about the pandemic is how much information has been shared and how quickly it's been shared. And you many times see science emerging almost in real time. And again, as someone who's been involved in, trying to understand, news and information his whole entire adult life. Cliff, can you tell us a bit about the work that you're doing with your research? And it talks a lot about trust. So first of all, tell us about your work, and then I have a couple of specific questions for you about the work you're doing.
Sure. Thanks, Scott. So back in March 2020, we launched the first in a series of studies called the COVID-19 Monitor, which is essentially a continuous longitudinal survey of Canadian attitudes towards the pandemic and pandemic-related policy interventions by the federal and provincial government. And so that study has been ongoing. It's now the largest sample of public opinion in Canada on attitudes towards the pandemic and pandemic-related policies. And it's been extended. We've run these studies in the United States, in Australia, in the UK, and in New Zealand, and try to get a comparative reference point about how different policy interventions have been received by the public and how different approaches to the pandemic or different messaging around the pandemic has impacted attitudes and behaviors among the public.
A lot of this is about trust. I mean, one of the things that we've published several stories on is what the term is infodemic. We've already talked a little bit tonight about the natural, some people don't trust government and they don't trust pharmaceutical companies. And although they may trust their personal doctor, they don't trust intellects and they don't trust people at universities. Why is that? And you know, what do you know about that from the research you're doing?
I mean, it builds from our earlier discussion, but I think, I mean, we've seen a rise in populism throughout Western democracies, certainly. And along with that rise in populism, we've seen really, I think, an unprecedented strain of anti-intellectualism, a rejection of science in ways that we have not seen in the post-war era. So I think this is tied up in ideological convictions and partisanship, but really also in polarization. It's no longer acceptable to have reasonable disagreements. I do think that the structure of public discourse on social media has conditioned us in such a way as to stick to our guns no matter what, to really not be permitted to make mistakes or reverse our judgment and even if that means rejecting the decades of scientific research that have been undertaken, and then also looking for signals that substantiate that existing bias that one has. So it's interesting, we've been told that the science is evolving and policymakers have told us that various policy changes and even some reversals, both at the federal and the provincial and at the global level with the WHO, these reversals have been justified by saying the science is evolving and we're learning as we're going. For a lot of people that we've surveyed, that honesty about the fact that, look, we just don't know until we know. Science is about discovery. Science is about generating hypotheses and trying to invalidate or to some extent validate those hypotheses with the best evidence at hand. But there are segments within the population that see that as actually a failure of science instead of the success of science. And that narrative has really taken hold among certain segments of the population, where there's this sense that science is now driven by ideologues, that those ideologues are actually not applying the scientific method. They are embedded in their own convictions, and the strength of that mentality and that attitude is quite striking. And again, I do think it's unprecedented, and I do think it's tied very much to the ways that we communicate with each other in 2021.
So the other panelists are all esteemed scientists and researchers. How does that make you feel? Because as a journalist, I'm used to people telling me I don't know what I'm talking about. I got a very thick skin. But I would think if I was in your shoes, it would be personally frustrating to see science and research being questioned so widely. How do you deal with that personally?
It has been since the dawn of time. Unintended dawn, but it has been since the dawn of time. There were women or people used to be burnt on pyres. We are no longer that medieval to burn on pyres, but whenever there is something so astute as to come, especially when it's unprecedented times like today, and there is anxiety all over, we always fear the unknown. So whenever there is an unknown out there that is at large, and then there is a group of people who are trying to say or spell out what that unknown is, that will always lead to issues, lead to conflicting views. I think that's what is going on, and what just now Cliff said made me think about all those things that, like, I'm just philosophizing right now, not really being scientific, but I think it's the social way of thinking that when you're seeing something unknown, trying to figure out something unknown, people are always fearful of the unknown and they don't want to know more. It's being familiar with what they don't know. For example, we were talking about natural immunity. They will come and tell you, oh, but I had measles, I never got measles again. So it's the same thing. If I got COVID, I'm not going to get reinfected again. But those who study immune system, they know that every individual is unique and every germ is unique. So how an individual will respond to a germ at a given time point in their lifetime is unique. So, and this is what is very difficult to put across, because everybody will have their own story, which I have been trying to listen. I promise I have been. And they'll come up with something like, I got measles, I never had measles again.
Yeah, this isn't measles. It's something different.
Measles is completely something different. Same thing to do with, I guess, even SARS and MERS. Everybody's like, oh, well, we didn't have this problem of long COVID, like we didn't have a long SARS. And I think about it saying that viruses are notorious to cause such issues with your immune system. So there is something called as post-viral syndrome. The reason why this whole long COVID has become such an issue right now is because of sheer numbers. We are dealing with much more numbers right now because 93% of the COVID infected world have recovered. So there will be, even if it's 10% of that we are looking at with lingering symptoms, the numbers are huge. Post-viral syndrome or post-viral immune system issues are not uncommon. It's not unknown. It's the numbers.
Zane, we've seen across the country people actually protesting at hospitals. My father was a doctor. He would not have responded well to that. Let me just put it that way. You already talked about people being burned out. How do you deal with that? How do you go to work every day?
Yeah, it's tough. I mean, I think you have to put your instincts aside and recognize that this pandemic has been hard on every person in every different way. And a lot of the time the antagonism is from a place of fear, it's from a place of disappointment, it's from a place of insecurity, it's from a place of someone that's had very poor outcomes with the pandemic and livelihoods being lost. And so I think we all reflect on that some of these protests or some of these actions are inspired by people that have suffered, and this is just an outward motion of that suffering. But it is tough, and for the people, the healthcare workers that have worked every day vigilantly, that have scaled up, that now thought they were going to have a great Christmas vacation, that are being pulled back and being said like prepare for the worst part of the pandemic. I think it obviously is demotivating for people to see it. And certainly when there's any issues with personal safety, there does need to be a line drawn here, particularly that people should be able to work without necessarily feeling unsafe in their environments. But I think as this wears on, as this gets difficult, as people, suffer one way or another from the effects of what's happened, it's going to be worse out there. And I think we expect that there is a part of society that has just suffered a lot with this and wants to disregard the science and disregard the politics behind it.
So we've gotten some questions that have been coming in since we started, and I want to address a couple of them. So one question here is about concerns because we're injecting the disease into people. That's not true, is it? Dawn, do you want to tell? Again, this is one of the myths. Another one is a question about stem cells. I don't know what that is. I mean, I know what stem cells are, but I don't understand why that's an issue for someone in terms of the vaccine. So Dawn, can you address, these are some of the things, I think, Cliff, you probably deal with these a lot in doing your research on the right type of information people should be trying to source their decisions on.
Yeah, it's unfortunate that there is this confusion because some vaccines in our repertoire do include a killed virus, sometimes even alive. In the case of the BCG vaccine, which is given to people in places of the world where tuberculosis is endemic, that's a live bacteria. And sometimes that works really well. You show the dead virus or you show the bacteria, and that stimulates an immune response. The current vaccines we have for COVID are neither of those things. So we have the messenger RNA, which encodes a tiny little protein that looks like the spike protein. If you've seen that gray picture of the virus with the little red things sticking out, the red bits. And then your immune system, your body makes that spike protein, your immune system chews it to pieces and then creates antibodies to that spike protein. Our other vaccine is the one that's sort of the AstraZeneca model, where we do actually hollow out a different virus, a common cold virus. We scoop all its stuff out and we put some of the material to encode, again, those spike proteins. So there's no infecting people with live viruses. There's nothing like that. Other parts of the world do have vaccines that use those sorts of different technologies, but the ones that are approved in Canada don't have that. And in fact, there is a movement to create other protein-based vaccines that are made a little bit more like our influenza vaccine for people who do have those concerns about using mRNA or genetic material in that. But we are definitely not. The horrible sick feeling you might have after you're vaccinated, and I can speak from experience because I was out cold for 24 hours after my second dose, is your immune system doing its thing. So it's causing you to respond and have a really profound immune response. And unfortunately, some of that feels like getting sick. So you're not getting sick with the virus, you're just having your immune system get really excited. And so many of the things we feel when we get sick are actually a feature of our immune system. And that's what we see in the context of vaccination.
Got a question about long COVID. How can someone determine if symptoms that you're experiencing were due to long COVID if you were never diagnosed with COVID in the first place?
It's very difficult to answer that. And again, I will answer that with what I already was trying to say. It was embedded in my answer before. Early on during the pandemic, the PCR tests were not available to everybody who was symptomatic. So a lot of them were asked to isolate, self-isolate at home. It could have been very well that you could have had some other virus that was circulating. It could have been anything. It could have been one of the common viruses. And what you are experiencing right now is possibly a post-virus syndrome. And because there is so many people out there with long COVID symptoms, it is very likely that you might end up thinking that, oh, I have the same thing. Now, can you get a PCR test now to confirm? No, because the virus is possibly shed, so you will not know. Does the body leave a fingerprint? Yes, usually it does leave a fingerprint in the form of antibodies. But now what we know from research is that the antibodies that are generated by the body against the infection, it wanes out. So we may not even catch it in time to confirm whether you had the infection or not. So there are ways, I know that Dawn and her research, and her colleagues are working on getting these serology testing to figure out if the person ever had the natural infection, but it's not a confirmed, conclusive thing. So I think you just have to make your peace with it, that I had some sort of a bad infection during the early pandemic times. I'm having a post-viral situation and I need to treat it like that. Maybe it's COVID, maybe it's long COVID, maybe it's not. It's a post-viral.
Just help people understand by serology, that's a blood test. Is that what it would be?
Right. Serology is basically blood test. So you see the blood test and you see if you have the antibodies that can recognize any part of the SARS-CoV-2 virus. And there are 3 specific parts that Dawn's trying to look at, and many other researchers in the world.
So we had a question sent in to us about someone who's homeschools their kids, and therefore they believe that minimizes exposure to others. And again, you hear this from some people. So I don't get out much, or I don't work in an office, or I work outside, so therefore I don't really need to be vaccinated. how would you respond to someone who said something like that?
Yeah, I can take this. So I have seen people who have tried their best to isolate people that were homebound but are reliant on certain people to be in their environment for their care that have gotten COVID. So number one, it's reducing your contacts and staying at home will reduce your risk, but it's fallible. There are ways that people can get through it. People have to still go to the grocery store. People eventually have to see family. People have to get on public transit and other ways that people can get exposed. Number two, look, I think there is this overlying belief that COVID-19 is somehow going to disappear from the face of this earth, and it's not, right? And this is going to be one of our endemic viruses. It's not there yet. We're still seeing epidemic spread, but this is going to be there today. It's going to be there tomorrow. It's going to be there the next day. And so unless you plan on you and your family living a lifestyle where you're going to be homeschooled and staying at home for the foreseeable, decade or two, you're going to encounter COVID at some point or another. And again, the best thing you can do for your body is have immunity to the virus and have a head start so that when you are encountering this virus, you can deal with it. And, again, doing those things to reduce contacts and minimizing chances to get infected are great, but they're not sustainable for 5-10 years. They're going to be sustainable for a short amount of time in that sense.
Help us understand the difference between pandemic and endemic, because we are starting to hear the term endemic come up.
Yeah, I mean, we talk about our endemic infections, like our endemic respiratory infections, endemic influenza, and these are, at a stable rate. We do see spread that comes and goes. There's a seasonality or a pattern to it, and it is part of our ecology and part of our interlinkings with the world. Pandemics and epidemics are really when you have susceptible populations that can get infected exponentially at high growths. And we are still in that phase in many places in the world. In fact, places in the world that have only had natural immunity to rely on due to our inequity issues are still seeing epidemic spread. I mean, South Africa, again, we're talking about the Omicron variant in a population that likely 80% of it has had COVID at some point or another. And so, that is when the immunity in the population can balance things. And again, you see more rifts and valleys than you do see kind of these epidemic waves and curves. We're not there yet. And again, this virus keeps changing to the point where we keep seeing epidemic spread, every few months from a new variant or some other issue as things go forward.
So it's the time of year where, regardless of whether this is Christmas is a religious holiday, it is the time of year that all Canadians get together to celebrate. And at the same time, Omicron is coming out. It just seems like we can't catch a break. We actually had a question from someone who has tickets to attend a play in Toronto. And even though everybody has to be vaccinated to get in and you have to wear a mask. So what should we be doing over as the holidays emerge? What will you be doing? Will you be taking any extra precautions? Let's quickly go around, and then I want to finish up because we're almost out of time. But I have a final question for Cliff before we wrap it up.
So I'll say mine, and then feel free to go around. So I think, again, knowing that things are going to increase and that we do really want a family gathering at Christmas, a small one for just our very immediate family, we're going to take it easy from our other contacts and really limit them to the things we need to do for day-to-day life, but skip all the other restaurants and sports games and that type of thing in that sense, and really just try to take it as easy as possible to that gathering. And being very cognizant of our symptoms over the next little while.
I have declined to attend a family event with our unvaccinated relatives, despite the fact I love them and miss them. A multi-home event with people who are vaccinated and unvaccinated, because I know statistically that is associated with spread. And so I've made that. On another family event where we'll have 12 people, we've gotten everyone who's eligible boosted 7 days prior. So I'm pretty happy about that. So all my older relatives who were eligible have now are going to have some protection, and the whole 12 of us will do rapid tests before we attend the meal. And that's the two events. And other than that, we'll be ordering some takeout and having some movie days, but we'll be spending time at home and not going out.
Zane, I know you have to leave. Thank you very much. It's been great. And just before we wrap on Manali, do you want to talk about that last issue about thoughts on the holidays and your personal plans, your personal precautions?
You know, most of my family is across the globe, so it ends up being virtual, and the extended family that ends up being like close friends here, they're all of them who are vaccinated and who I know are cognizant of their symptoms. We are deciding to have rapid antigen tests done before we even meet. But I am very sure, like the rounds are happening on the WhatsApp right now. Should we have it? Should we not have it? So I have a feeling it's all going to get canceled as we go. If there are any events that happen with a low number of 10 people, maybe in the closed bubble, we will be making sure that they are double vaccinated or with boosters, getting a rapid antigen test that morning. And anybody with symptoms, even the rapid antigen test is not conclusive, needs to get a PCR test to confirm. So, yeah.
Cliff, I want to, as someone who's taking the pulse of the public all the time, tonight we tried to answer some questions. We've tried to, perhaps those people who are hesitant but open to vaccines. Do you think that at this stage, almost a year to when the vaccines have been available, is there anything that can be done to convince those who haven't been vaccinated to actually make that decision now?
I think there are some difficult decisions that policymakers have to engage with around this. We've seen the efficacy of mandatory vaccinations in certain sectors, and that has led to people who don't want to be vaccinated, but nevertheless have made the decision to be vaccinated based on the policies that were put in place. That's not something that should be done lightly. People are, I think there are reasonable concerns about the government imposing mandatory measures, but there are choices to be made about the collective health of the population. And I will say that what we see in the data of public opinion is that the people who are reluctant to get vaccinated are not a homogeneous group. There are different clusters within that group who have different motivations, ideas. They're basing their decisions on different information and intuition and feelings. And they have different interactions with the public healthcare system. We also have to think about equity deserving communities and racialized communities and differential uptake among those communities for reasons that we can't always immediately ascertain or empathize with. So I think there's not a one size fits all approach. There are people who will not be vaccinated unless they are made to be vaccinated. And again, the extent to which the government wants to impose that kind of mandate is not an easy thing to deal with. But in terms of what we can do, I think it goes back to almost the beginning of the conversation and the really insightful things that my colleagues on this panel have spoken about, which is certainly any frame or any conversation that seeks to patronize or belittle the reasons that people have for not getting vaccinated is probably not going to end up being a successful path to convincing them otherwise. I think there's, we talk about, we've tested the information that people have on vaccines who choose not to get vaccinated. And these are not, by and large, people who haven't read anything or who haven't looked up information on the vaccine or who haven't taken this very seriously. They do take it seriously. They read a lot about it. But, there have been decades of concerted efforts to undermine science when it conflicts with certain interests. Look at the science on climate change, for example. This is not something that's new. That has eroded confidence in science in general. And we have also consistently underfunded STEM in our public education systems. And that lack of funding has led to an inability to discern authentic information from disinformation and misinformation in the broader public. So it's almost a perfect storm of institutional and political failings that has led us to this point. I don't fault individuals. I by and large, I think we have to think about the system that has led us to the place in which we are now.
On that, I'm going to turn it back to Wade. But before I do, I want to thank all of you. I want to thank McMaster, and I want to thank those of you who have been submitting questions. We hope we've made a difference tonight. The struggle continues. And Wade, back to you.
Thanks very much, Scott. I want to say thank you very, very much to all of our panelists, Don, Manali, Cliff, and Zane, who understandably had to leave. All of you are so busy, so intensely involved with this crisis. And hearing you, seeing you, it brings me comfort and belief to know that these steady hands and many others are at the wheel of this crisis. And I thank you for sharing your knowledge and wisdom and experience. I thank you for your dedication to public health. And it is so admirable. And we hope that the test doesn't last much longer, but we know you're up to it no matter how long it goes. I want to thank you, Scott, our host. You've so ably guided this conversation. Your journalistic talents were well in evidence tonight as you helped to interpret and to weave in questions from the public and make sure that everything that could be answered in this short time was answered. I want to thank your teammates at the conversation, and particularly Hannah Hogue. I want to thank my McMaster colleagues from the Office of Alumni Development who have facilitated this event so well and made it run so smoothly. And they include, but they're not limited to, Karen McQuigg, Christine Kennedy, Dave Dawson, and Shelley Zhu. I want to thank my colleague from the Office of Communications, Marketing, and Public Affairs, Monique Beach, for her facilitation. And on behalf of everyone here, I also want to say thanks very much to those audience members who have stayed with us for this hour, who've cared about these issues, who've contributed their questions, whose questions form the basis for this conversation. I want to wish everyone a well-informed and healthy year to come. Thank you.